Hello everybody. Over the next few minutes we will discuss how you assess the performance of AI software for prostate cancer detection. Here are my disclosures. Over the next few minutes I hope to start off by showing you how the limitations of the MRI pathway can be addressed using computer-aided detection software. I hope you will realize what the diagnostic performance should be of a software to help you deliver a successful MRI prostate cancer diagnosis pathway. There is a difference between a diagnostic aid and an expert second opinion, and I will go into that, and I'll expand on what other tasks the AI needs to be able to address for you to be able to influence biopsies and for therapy planning. So you should now be aware that there are four major benefits to the MRI pathway. The first and the most important, of course, is the reduction of the number of patients undergoing biopsies and therefore the number of patients being diagnosed with indolent disease. And this speaks to the rule-out ability of MRI. But there is also another advantage in the improved detection of high-grade cancers and a better risk stratification of the tumors that are diagnosed with an MRI targeted biopsy, and this speaks to the rule-in ability of MRI. And if you look at the Cochrane analysis, these advantages are in fact emphasized. You can see that on average, about 33% of men will avoid a biopsy. You will have a decrease in the prevalence of clinically insignificant cancers by about 9 or 10%, and there is some improvement of the detection of clinically significant disease, particularly in men who have undergone a previous negative biopsy. Now, there are uncertainties associated with these claims. We know that the rule-out ability is in fact very good. The high sensitivity and the low negative predictive value of MRI means that you can effectively deliver biopsy avoidance, and you can see that on the graph on the left-hand side, where there is very low variability between a number of centers in the UK, for example. On the other hand, you'll see that the rule-in ability is in fact quite variable, and this is looking at 25 centers mostly in the USA. And you can see how the positive predictive value varies from 25% to about 75% and averages out about 50% of times. So in other words, what we're saying is that in men who have a positive MRI, there are still numerous lesions that turn out not to be cancers. In other words, too many false positive lesions in men considered to have positive scans. And when you do the math, what you notice in this particular analysis is that 45% of men with a positive MRI, in other words, PIRADS 3, 4, 5, don't have high-grade cancer diagnosed. And this is a real issue. There are, of course, other issues, such as the quality assurance and the quality control of the MRI pathway. We know there's a steep learning curve for image interpretations and for biopsy performance. We know there's a large variability between radiologists and within radiologists. We know there's radiological burnout going on because it's time intensive to perform, review, report, and lesion contour all these additional prostate MRI scans that we are doing. And finally, we know that in about half the cases, the dynamic contrast enhancement that we use is not helpful for diagnosis, and that's wasted resources, both in terms of time pressures and, of course, gadolinium that is not useful. So one can see that there are a number of roles that an AI could play, and it could span a number of roles from data acquisition down to pathological assessments. But today I'd like to focus in on the image interpretation of the images. So what should you expect if you're going to buy or think about using an AI tool to help in that function? Well, firstly, the AI should ensure that the current benefits are met. And the current benefits are from biopsy avoidance. So you want consistent and high negative predictive value, and sensitivity. Number 2, it should help you decrease the detection of false positive cases. Remember, the false positive rate is widely variable, averages out at about 50%. So you want to improve consistency of patient-level PPV, and you only want to identify lesions that are likely to be higher-grade cancers. Number 3, an AI should be able to help you for PIRADS3 cases. In other words, increase the specificity when you see a PIRADS3 lesions. AI should help you in your productivity by decreasing these time-intensive reporting and outlining tasks. And of course, the AI should be logical and stepwise so that the outputs are actionable and therefore contribute effectively to MDT working. So we can really think about 3 major tasks for an MRI. The first is at the patient level. It should not detect men who do not have clinically significant disease. In other words, the focus should be on excluding patients who are unlikely to have clinically significant disease, and that, of course, is with a high sensitivity, negative predictive value with the lowest possible false positive rate. And here is an example of an AI saying, don't worry about this patient. So you can see the yellow arrow shows you a soft tissue abnormality. The AI is saying, forget this. It's nothing to worry about. Okay, so it's saying, forget it. And in fact, if you follow this man for the next 5 years, you can see this area of TZ fibrosis just stays the same. So the AI was correct, and over 5 years, it was proven to be correct. The second major task is to say, is in people who are not excluded, is to identify lesions that are most likely to represent clinically significant disease. In other words, to reduce the number of false alarms that are happening in your prostate MRI scans. Here is an example. So you can see that this man, who's 52 years old, no family history, has a slightly raised PSA. You can see his PSA density is 0.11. The AI identifies 2 lesions in the peripheral zone, but a false alarm reduction engine gets rid of the lesion in the right peripheral zone and says the only possible abnormality here is in the left peripheral zone in the midgland and apex. Now, this man does not undergo a biopsy. He doesn't want to undergo a biopsy because there are no big risk factors, and he, in this particular instance, is biopsy averse. But look what happens to him over the next 6 months. His PSA continues to rise. His PSA density goes up. So now he's more worried. Now he's become cancer averse as opposed to being biopsy averse on the previous occasion. And look what the AI says on the follow-up study. Both abnormalities are in fact now positive even after the false alarm reduction engine is switched on. So it's showing you there are bilateral abnormalities that need to be biopsied. Lastly, the task is on biopsy management. Here, of course, the emphasis is on the gland, delineation, the lesion outlining functions, etc. So we can see there are 3 tasks that we need to focus on, and here's an example of an AI software that does those last functions. You can see the prostate gland is outlined, the transition zone is outlined, and this large tumor is also outlined, just to show you an illustration. So how should an AI software be organized to deliver the advantages that you want? Well, the first one is gland segmentation. The second is the detection and the localization of lesions. The third task is classification of the lesions. The fourth is to get rid of false alarms, and the fifth is mapping this on and for contouring purposes. So this is a typical multi-stage architecture that you would expect from a modern AI detection software system. And of course, the interface for you to be able to interact should be logically laid out, one screen rather than multiple screens. So when you're evaluating this software, there's two things you need to do. You need to evaluate the software as a diagnostic aid and as a tool that would support biopsy decisions. So in fact, these are two separate tasks. A diagnostic aid helps you perform your work more accurately and consistently regarding your primary role, which is diagnosis. So in other words, it should be consistent at saying this is positive or this is negative as a scan. Okay. So in other words, the evidence that you need is against other radiologists in terms of accuracy and workflow compared to other radiologists. And you can, of course, have a basic functionality or an advanced level of functionality. Now, when you evaluate an AI tool for biopsy decisions, this patient needs a biopsy, this patient does not need a biopsy, then of course the level of harm is higher. So the evidence in this particular instance is against pathology, not against a radiologist. So a much higher level of evidence, and of course in this function you have to integrate other clinical parameters such as PSA and family history into biopsy management decisions. So in fact there are two separate evaluations that need to be done, both as a diagnostic aid for radiologists, but separately as a tool for improving the detection of a higher grade cancer. Remember that when we evaluate CAD against a radiologist, we're looking at the potential benefits and the potential harms on the need for a biopsy, whereas when we evaluate a CAD software against pathological assessments, the harms and the benefits are as they relate after the biopsy to patient management. So we have to remember that these are separate contexts, because a false reassurance on the left is not the same thing as a false negative. A false reassurance results in a delay in a biopsy, whereas a false negative results in a delay of a treatment of an important cancer. Different. A false alarm is an unnecessary biopsy and harms related to the biopsy. A false positive is potential overtreatment of indolent disease and long-term active surveillance costs. So here, for example, is a small lesion in 2018 which is missed by the AI. You can see that 3 years later, the AI diagnoses this cancer. So this was a false reassurance in 2018, resulting in a delayed diagnosis and delayed management of a high-grade cancer by 3 years. So I hope it's clear that, in fact, there needs to be two separate evaluations, as a diagnostic aid for radiologists and separately as a tool for improving the detection of clinically significant cancers. So coming back to the three tasks that we discussed earlier. The first task was excluding patients who are unlikely to have clinically significant cancers. What sort of performance would you want at a patient level for an AI software? Here, remember, you have to compare yourself to other radiologists. So the patient level sensitivity and negative predictive value needs to be more than 90%. The patient false positive rate, remember I said it was 50% on average, so it has to be less than 50%, and the lower the better. And of course it's important to have a low variability of readings. So is AI able to help you exclude patients who are unlikely to have clinically significant disease? So here is some recent data looking at the accuracy of radiologists compared to their peers for looking at the detection of PIRADS 4 and 5 lesions. What you'll notice is that an unaided radiologist at a 90% sensitivity will have about a 38% false positive rate. We said that the false positive rate for a radiologist should be less than 50%, and in this particular instance, it's 38%. Notice what happens when you use the AI. there's an improvement in the false positive rate. So the number of false positive actually reduces to 28%. So it's about a 10% improvement in the false positive rate with the use of the AI. And when you look at the radiologists themselves, you'll see that they miss fewer lesions using an AI than without the AI, which is good to have. But you'll notice what happens to the false alarm rate. The false alarm rate for some radiologists, in fact, increases. For 3 out of the 7 radiologists in this study, the false alarm rate, in fact, increases with the use of AI. So there is a tendency to show you lesions that, in fact, aren't cancers. So, for example, here's a small cancer behind the fibromuscular stroma anteriorly in the prostate gland, and the AI says, look, here is a lesion. So that is a true detection. But look what happens at the base. At the base, the AI is detecting a false positive lesion. So if you believe the AI, you would have called this lesion, but you would also have called this lesion. But as radiologists, we know that this second lesion, in fact, is just the central zone. So false alarms for some inexperienced radiologists will, in fact, increase. And when you look further at this software, what you notice is that it does improve the consistency between the readers. So you can see how the kappa values improve with the use of the AI, which is something that we wanted to know. The second issue is, does this mean that we detect more clinically significant cancers using this software? In fact, there's very limited data on this particular software. But what we do know is that it reduces the number of patients with indeterminate or PIRADS 3 cases. So you can see how there are a number of radiologists who have a PIRADS 3 prevalence of anywhere from 10 to 15%, and the AI brings it down to 1%. So this is something that we wanted. We wanted to reduce the number of indeterminate cases, and AI can help you decrease the number of indeterminate cases. But if you look on the right-hand side, you can see how that AI performs in terms of detecting clinically significant disease. And in this particular instance, you see that for the inexperienced user, the AI definitely improves the detection of high-grade cancers, but you'll notice it doesn't reach the level of the expert reader. In this particular instance, expert number 4 and 5. It just doesn't get that high. So it improves the junior radiologist's performance, but it doesn't get as high as a senior radiologist. Another study with a different software has also looked at this ability of AI to detect clinically significant cancers. And in this particular instance, what you'll notice is that the CAD performance matches that of the general radiologist. So the general radiologist, for example, in the MRI first study, were 16 general radiologists working in clinical practice. And you can see that the AI performs as well as the general radiologist. But the AI does not perform a highly specialist radiologist expert level, where you expect a lower level of false positive rate, because you can see, for example, the 4M radiologist had a much lower rate of false positives than a general radiologist. And this is something that we saw previously. A general radiologist would be expected to have a false positive rate of 50%. In this particular instance, you can see a specialist radiologist brings that down to around about 30%. So 20% reduction in the false positive rates using the AI in this particular instance. So the AI is not performing like a specialist expert radiologist. Remember that task 2 was about reducing the number of false alarms in patients. And ideally, we want less than 1 false alarm per patient. So let's look at these 2 pieces of software and see how well they do regarding their false alarm rates. So in this particular instance, we don't use ROC analysis, we use FROC analysis. And on the left-hand side, you can see that at the 90% sensitivity, the false alarm rate was between 1.5 and 2 per patient. So in other words, for each patient that's not excluded, we are getting between 1.5 and 2 false alarms per patient. On the right-hand side, we can see that that software performs slightly better. Again, at the 90% sensitivity, you can see the false alarm rate is around 0.7 per patient. And that is better than 1 to 2. So we want as low a rate as possible, ideally less than 1 per patient. And remember, task 3 is about prostate gland delineations, about lesion delineations, because this is about biopsy management. And when we talk about biopsy management, of course, the gold standard, of course, then has to be pathology. In other words, the software has to generalize to high-grade cancer detection, whether you define that as grade group 2 and above or grade group 3 and above. So there are a number of questions you need to ask yourself when you think about which sort of software you might get. Do you really need radiological assistance, or do you really need an expert system? And what is your task priority? Is it identifying men at low risk of having high-grade cancers so you don't have to read these cases? Or are you interested in minimizing the number of false positive cases and reducing the number of false positive lesions? Or are you really interested in the AI for biopsy management? So there are different criteria you need to apply depending on what your task priority is. Is it going to work with your data? Will it integrate into your workflow? And does it have a features list that you need? And how much is an assistant versus an expert system worth to you? Regarding the features list, here, for example, is the current level of functionality, which is at the level of a radiological aid, although there are still missing pieces of functionality in some of the systems that we see at the moment. But as we think about future functionality for an expert system, then we would want more features, and those are highlighted on the table on the right, and you can read these at your leisure. So where are we today in terms of developments of AI software? We've certainly got promising results against radiologists, against histopathology, and for gland and lesion segmentations, and we see academic as well as commercial software becoming available. But is it really ready for prime time for the general radiologists? I think we have to acknowledge that the current level of performance is probably a bit too optimistic because there is overfitting to a limited diversity of data sets. There's very minimal independent or external validations of the developed AI systems, and challenge datasets are now being developed to test the generalizability of these AI systems on a variety of cases. We certainly haven't had much head-to-head comparison against the current standard of multidisciplinary care. And of course, there are multiple outstanding legal and ethical issues that we still need to work out. So here are my final remarks. The current AI software delivers a consistent level of performance that is equivalent to an average radiologist with average levels of false alarms and false reassurances. In other words, it can serve as a diagnostic aid. However, it isn't ready as a decision support tool, which will require multicentric, multi-vendor validation studies against a stronger histological standard, which is histological validation, which is not yet available. However, there should be no doubt that we will need AI assistance for a community-wide MRI-driven prostate cancer diagnosis pathway, both for men who are suspected of having cancer and in screen-detected settings. There's no doubt about that. Thank you very much for listening. I hope you found some of these remarks helpful.